Hello. We're so glad you joined us. I'm Dr. Juliann Paolicchi, and I'm a pediatric epileptologist at the Northwell Epilepsy Program. I'm also a professor of neurology and pediatrics at the Hofstra Northwell School of Medicine. I have the pleasure today of filling you in on some very exciting updates in the field of pediatric epilepsy. The first question I always get is, how are children different in terms of epilepsy from adults? And as we go along, I'm going to be focusing on that question. The most important and the first thing that we focus on as pediatric epileptologists is what causes the epilepsy. This is always the primary question that parents ask us, and as physicians we typically go through a series of tests so that we can really figure out why someone, especially a child, may have developed epilepsy. In this slide, what we're seeing is from birth till later in life, there's different reasons that people have epilepsy. Early in life, it tends to be more because of early birth injuries, problems with metabolism, genetic forms of epilepsy we're learning a tremendous amount about, and I'll be focusing on that too. Infection and birth malformations can all be reasons why a child can have epilepsy. It's not till later in life that we worry more about things related to stroke, brain tumors. And of course, trauma is always on here as a possible cause for anyone to have epilepsy as well. The types of seizures that we see in children are also different than we see in adults. When we look at this graph, this is the types of seizures that people have. About 50% of adults have a seizure type that used to be called complex partial. We now call it focal with impaired consciousness. And another 13 also have focal seizures. This means that approximately 70% of adults have seizures that come from one part of the brain. Children are different. There's a greater variety of the types of seizures, but for children, focal seizures comprise less than 50% of seizures in children, and generalized seizures tend to be significantly more common. Generalized seizures tend to come from all over the brain, and they require typically a different approach to treatment. The majority of the new medications that come available to treat epilepsy tend to focus on the adult model, tend to focus on focal seizures. And that means there's often a lag between when a new medication or treatment comes out and when we have the availability and research to utilize it in children. This shows us a graph of the years from the early 1960s all the way up to present time at the real explosion of new agents that we have available to treat epilepsy. This early part of the graph was called first generation. Next, from the 80s and 90s, was the second generation. But really since 2000, with the explosion of research and better understanding of epilepsy, we also have an explosion in medications that are available. Unfortunately, there is, as we said, sometimes a lag between when we have that available data to use those medications for children. I should also let you know that we have a very robust research program here at Northwell where we utilize these newer medications in a very controlled fashion in pediatric populations in order to see whether these medications are safe and efficacious and what dose is appropriate as well. How come the treatment of children with epilepsy is so challenging? Well, I'm often asked this question as well, and it comes back to our etiology slide. Yes, you saw that graph once before, and that's because taking care of an abnormality that occurred before birth that then results in epilepsy can be very challenging in terms of its treatment. In addition, this category, the genetic epilepsies, again, I mentioned that there's been an explosion in terms of the research available in this area. We are able to uncover more of the genetic etiologies for epilepsy, but we're still in the process of developing specific treatments for them. I'm going to talk a little bit about another factor that comes into play here, and that is medically refractory epilepsy. That's a big term, but what does that mean? It occurs both in children and adults, but we know from research that if we utilize the first medication for the treatment of seizures, about half of patients, including children, will be seizure-free. These, of course, are the lucky half. We choose an appropriate medication, they take it, they tolerate it, and their seizures are controlled. Unfortunately, if that first medication does not work, and we have to move on to the second medication, only an additional 11% of patients will become seizure-free. A third drug is even smaller, an additional 4% will become seizure-free, and that leaves us with about a third of patients, including children, that are just not responding to these therapies. I'm sure you're thinking, well, Dr. Paolicchi, with all these new therapies, hasn't this number changed? And interestingly, over time, this data has been reproduced, and it still remains about a quarter of the patients still need additional therapies beyond standard medications. The recent updates. Several years ago, we were all very excited about the utilization of organic therapies, in particular cannabidiol therapy, in the treatment of epilepsy. It was first approved for some of the childhood epilepsies, in particular Dravet syndrome, which is a genetic form of epilepsy I'm going to be discussing in just a little bit. It was then extended to another very challenging form of epilepsy in Lennox-Gastaut syndrome, and then became available for other epilepsy syndromes. Another exciting development in this field was the approval of a pharmaceutical grade cannabidiol that we're now able to prescribe for patients. And we have utilized this fairly extensively in our patient population. There's also been some very exciting updates in how we can stop a seizure. Now, even with the best of treatment, there can always be a time when someone may have a breakthrough seizure. So what do? We have in the past had a suppository of diazepam that's available to use. Obviously, there's a lot of difficulties when a child may have to take a suppository to school, child would have to use a suppository in the mall or at the playground. So there was a lot of challenges in terms of the actual utilization of this therapy. Fortunately, there now are some additional therapies. Some are dissolvable and some are now nasal, that we can prescribe in case someone has a breakthrough seizure and gives the patient more control over their epilepsy. In addition, we talked about this curve with the explosion of the medication, and there's been ongoing research that demonstrated that there is similar efficacy for patients with epilepsy across the age spectrum. And so the FDA began offering approval of medications, especially if they've passed safety, dosing, and efficacy standards. So there's been a faster pipeline from determination of a new drug to its use in children. Two drugs in particular, perampanel and lacosamide, first approved for use in adult patients for those focal seizures, but we found actually have efficacy for children with generalized seizures, and therefore allowing us to treat a greater population of children. I'd also like to talk about, however, what's on our future. And you've heard a lot of information about personalized medicine. What does that mean? In a more standard way of thinking, we'll call that traditional therapy. Patients have a same diagnosis and they're given the same treatment. However, we know as individuals we'll all have different responses to that treatment. So is there a way for that to be more targeted, for us to have a better response to therapy without side effects? What we are now doing is a lot more genetic and metabolic testing in order to determine, is there a targeted therapy for the patient's underlying diagnosis, and are there alternative therapies that that particular patient with that particular molecular diagnosis will be responsive to? Here are some of the new medications, new availabilities that we have based on this more personalized medicine track. I'm going to focus on some of those in particular. I mentioned a very complicated syndrome that we do see in pediatrics called Dravet syndrome. In that, there is a very specific mutation of how sodium gets into our cells. Sodium is very important in terms of the activation of epilepsy, and so it can greatly increase a patient's epilepsy. However, these patients have other difficulties as well. They can have prolonged and frequent seizures, loss of developmental skills, intellectual disability, problems with walking, speech impairment, and even if severe, autistic-like behavior. There are many different mutations that can cause the Dravet syndrome. So we need something focused in order to help these patients. And what we found was patients who had the specific mutation do respond to alternative therapies, in particular dietary therapy. CBD in particular seemed to be more effective for these patients as opposed to traditional therapies. And two newer medications, stiripentol and fenfluramine, were also developed and tested in terms of the use of this very specific syndrome. I show this as an example of a specific gene defect causing specific problems and therefore directing our therapy. And that really is much more the direction we're going in the treatment of pediatric epilepsy. Here's another example, a disease called tuberous sclerosis. In this case, there's two different genes that can have a mutation. And again, like I showed in Dravet syndrome, it doesn't just affect the brain. It can affect the skin, it can cause growths in the brain, it can affect the kidneys, the heart, and other parts of the body in terms of too much growth. The exciting thing is that the FDA approved a very specific tablet, first for the brain growths, and then for the renal growths, but it was found to also be helpful in reducing the seizures in children as young as 2 years of age who have this genetic disorder. So again, this is an example of very personalized medicine where a child has epilepsy. We make a genetic diagnosis and then know the specific treatments for that patient. I'd also like to talk about some of the newer technological advances that are occurring for the treatment of children. They fall under a category that we call neuromodulation. Although that's a fancy name, fancy term, what it really implies is that additional low amplitude stimulation of the brain can with time set up a feedback loop that therefore decreases the activation we see in epilepsy. That sounds like a lot to grasp, but if we think of it as epilepsy being too many discharges and neuromodulation dampening that response, that's a good way to sort of conceptualize how it works. We currently have several available therapies for neuromodulation. The vagus nerve stimulator came out several years ago, even more than 2 decades ago, but just recently has been approved for children as young as 4. In this case, there's a generator that's placed just under the skin. A lead goes up and attaches to the vagus nerve, and through natural connections from the vagus nerve, this stimulation is spread throughout the brain in order to dampen that electrical response. The other exciting thing about this device is that patients can carry a magnet, and if they sense a seizure, can actually increase the activation of the device, which stops a seizure. Again, that's all well and good if a patient knows it's happening, but newer modulations of the device have caused a sense where there's an automatic stimulation. In other words, the device, through the generator, picks up a signal from the heart that a seizure is about to occur, causes an extra stimulation, and can decrease seizures. So this is an exciting option that we also have available for patients now as young as 4 with epilepsy. Another type of device that we're actually currently utilizing in children, it's not yet FDA approved, it is in adults, but has shown promise in the treatment of pediatric epilepsy. This neuromodulation device is actually implanted in the brain, right under the skull, with leads going into the brain structure themselves. These can be used twofold. First of all, it also has what's called responsive stimulation. In other words, if a seizure is felt, the patient can utilize a stimulus to show and go ahead and stop their seizure. In addition, with this device, there's a printout availability, so doctors who are in the epilepsy program, such as myself, can monitor the patient and determine how many seizures they're having and where they're actually coming from. Now, if you remember from my graph, I said that again, in children, most of the seizures are generalized. They're coming from all over the brain at once. So this device was again developed for focal seizures, but we are now doing further research and looking at if implanting the same device in the more general structures of the brain can overall dampen seizures, especially in children who have generalized seizures. I also like to talk briefly about technical innovations involved in the surgical treatment of children. Now that's a very scary thought, but there are children who are very amenable to surgical approaches for resection of surgery. What do we mean by that? That means we're looking for a very small area that's causing the epilepsy, and through more advanced techniques, pinpointing exactly where that is in terms of removing it. For many years, what was standard was the utilization of what's called grid and strip electrodes. In that regard, what we do is these grid electrodes are placed along the surface of the brain where we feel the epilepsy is coming from, and we can literally make a map of where epilepsy originates. We can also do stimulation to localize where a patient's motor and sensory area are specifically on the brain, so that if we do surgery, we can obviously eliminate epilepsy but not cause the patient any harm. And this had been the standard of care for quite a long time. Currently, however, we're able to utilize, even in children, a newer technique. And what we do in this regard is we play very, very, very small electrodes deeper in the surface of the brain, not going on the outside, but actually going into the brain, where, say, for example, we're interested in this region, very small electrodes could be placed. We can record the seizures themselves and actually do even more microscopic and fine-tuning of resective surgery. You can imagine that patients tolerate this procedure a lot better than they tolerate this larger procedure, which of course is the case. They recover better, and it also allows us to make a very closer identification of where the seizure focus might be. So that's just a brief update of what's going on in pediatric epilepsy. I crossed out the word update 2021 because what we really want to know is what's going to be 2022 and beyond. And with the advent of newer pharmaceutical agents, development of newer organic potentials, and number 3, further advances in epilepsy techniques, epilepsy procedures, even epilepsy surgery, if that's what a child needs, has really allowed us to move tremendously forward. Now, I bet you're wondering, I have a lot of questions. What can I do to get them answered? Well, of course, we're very, very open to having a discussion regarding your child and their epilepsy and what treatments are the best for them. I'm often asked, if my child is diagnosed with epilepsy and have to go on medications, does that mean that they'll be on them for life? Well, the good news is in children, they can very often outgrow their epilepsy. Many of the epilepsies, including the genetic epilepsies, are tied to an area of development. So we may see them early in school age, and they definitely go away as the child approaches puberty. So we work together in terms of the physician, the patient, what their studies look like to determine when is that time, and usually work together a time to come off the medications. For a great proportion of children, in about 2 years after the diagnosis of epilepsy, they can come off medication safely. Next question, many of my patients say, Dr. Paolicchi, you scared me with that surgery talk. Is that what my child will need, and at what point would we discuss it? Well, first of all, it's very important to know that only a small percentage of children will hopefully need epilepsy surgery. I did, however, mention and showed you the data that about 1/3 of patients will have medically refractory epilepsy. In other words, seizures that don't respond to medical therapy. It's in this group that we do like to consider what is a family's options. Could the child get surgery? Should the child consider neuromodulation? Should we be moving forward to organic therapies or dietary therapies? And it's that point when we see that 2 good medication trials have failed to produce the results that we want, that we encourage you to work in partnership with an epilepsy specialist so we can determine what fits that child's needs the best. And one of the third questions that I very frequently hear is, what about my child's development? What about their long-term learning potentials? How will it affect them in school? Well, it's important to know that, first of all, epilepsy is not as uncommon as we think. It can be present in about 10 to 25% of children at some point in their lives. And so the likelihood that some other child had a seizure in school is actually fairly high, much higher than someone would anticipate. In addition, we know that early control of the epilepsy gives us the best outcomes, not just in terms of the epilepsy, but also in terms of the child's development and learning outcome. So we actually work very diligently with families to make the treatment that's appropriate to the child, to control the epilepsy as soon as we can, to have them tolerate their therapies, because what we want is not just a child without seizures. We want a child who's able to participate in life fully and freely. Now that brings up one more question is, but Dr. Paolicchi, can my child do anything if they have epilepsy? Well, we always remind them that there are 5 things that they have to really keep attention for. The first one is that showers are safer than baths. If they're taking baths or if they're bathing age, then an adult must be present to supervise. Number 2, there always should be an adult present to supervise when a child is swimming, especially with epilepsy. Number 3, we encourage no sleeping on top of a bunk bed. Always sleep on a bottom bunk or on a single bed. Next is to avoid and take great caution with climbing high places. Typically, playground equipment can be safe, but in terms of climbing up very high trees or walls without a harness on, we recommend be restricted. And the last, most important that I remind every single child that I see is when we ride a bike, go on our skateboard, be on our scooter, we must protect our most precious organ. We must be wearing a helmet really at all times in order to protect them. I know what you're thinking, because most patients then will say, but Dr. Paolicchi, I already do those things, which is just what we want to hear, because those are standard precautions for overall protection of children. They're more emphasized if your child has epilepsy. On the other hand, they shouldn't restrict their life anymore. Again, it was a pleasure to speak to you today and hopefully give some insights on the very exciting developments that are going on here at Northwell in the Northwell Epilepsy Program. Thank you again.